Medicosis Perfectionalis CNS Pharmacology course. This is video number 3, barbiturates or the barbs. So let's get started. Can you answer this case? Please pause. And the answer here is, first they are asking about what? Diazepam, which is a benzodiazepine. How do benzos work? And the answer is E. They increase the frequency of inward current chloride channel. When chloride comes in, chloride is negative. When negative comes in, it's an inactivation. That's why you calm down, and it increases the frequency, not the duration. So benzos, they increase the frequency, but barbiturates, they increase the duration. And the mnemonic is barbiturates, duration. Dose-dependent CNS toxicity. Let's say that you keep receiving benzos and more benzos and more benzos and more benzos. You go this way, paradoxical disinhibition, and then anti-anxiety and sedation. Then benzos cause hypnosis, benzos cause anesthesia, benzos cause medullary depression. That's dangerous because the medulla has your cardiovascular center, breathing center, swallowing center, vomiting center. So again, these are the 4 centers in the medulla. Heart, lungs, get it in, swallowing, get it out, vomiting. But benzos will not cause coma and death. It doesn't mean impossible, it's less like. But look at the barbiturates. Oh, as you increase the dose, you increase the dose dependency in its toxicity, and it goes from here all the way up to coma and death. Some biochemistry, please. Do not forget that GABA came from glutamate, and you can thank vitamin B6. Do you know what's the name of the enzyme here? The enzyme here is the L-glutamic acid decarboxylase, or GAD. And then GABA transaminase gives you succinic semialdehyde. Bisuccinic semialdehyde dehydrogenase gives you succinic acid or succinate. It's part of the Krebs cycle or TCA cycle in the mitochondria to give you energy. Succinic semialdehyde plus glutamate, they go to something called the GABA shunt so that we regenerate and refresh the GABA cycle. GABAs make you calm down, but if they lead to disinhibition, they will excite you. GABA is inhibitory. This is inhibition, but inhibition of the inhibition is excitation. This is called double inhibition or disinhibition or paradoxical activation. GABA is abundant in interneurons, as you see. Activation of the GABA receptor will open the inward chloride channel. Chloride comes into the neuron. Chloride is negative. When negative comes in, this is inactivation or hyperpolarization so that you calm down. But do not calm down too much because you can develop coma and death. We have 3 subtypes of GABA receptors, A, B, and C. Which one is acted upon by barbiturates? Only GABA A. Barbiturates act on the GABA receptor, therefore barbiturates are inhibitory, therefore barbiturates will calm you down. GABA A receptor has all of these beautiful subunits, alpha, beta, and gamma. In order for the chloride channel to open, you need at least 2 alphas and 2 betas. So if I have GABA and benzo, will it open? Yes. If I have GABA and barbiturates, will it open? Yes. What happens when the chloride channel opens? Chloride comes into the neurons, causing hyperpolarization, which is inactivation. In the previous video, we learned that benzodiazepines will increase the frequency of opening of the chloride channel. And here is increased frequency. That's benzo, baby. But look at barbiturates. They increase not the frequency, but the duration of the opening of chloride channel. That's why barbiturates are barbiturates. They prolong the duration. This allows more time for chloride to come into the neuron, causing hyperpolarization and inactivation. What are the clinical uses of barbiturates? You can use them for seizure, to induce anesthesia, especially thiopental. So thio is for anesthesia. You can use it for drug-induced coma in cases of severe brain trauma. For this case, use pentobarbital. So pento for trauma. Sedative, they are hypnotics, muscle relaxant, anxiety, and insomnia. But no one will use barbiturates for insomnia. We use benzodiazepines today, especially the Z drugs, which are the non-benzos, such as zolpidem, zaleplon, izapiclon. Too much barbiturates can kill you. Mechanism of action. They also act on the GABA A, but they bind into a different site on the GABA A than the site bound to by benzos. This will increase the duration of chloride ions, therefore increase chloride influx, hyperpolarization, and inactivation with decreased action potential. Barbiturates are GABA mimetic. At high dose, they mimic GABA. They are inhibitory. They block complex 1 at the electron transport chain. No energy. No energy, you get CNS depression, respiratory depression, too much barbiturates, coma, and death. Antidote to barbiturate overdose? There is none. But to benzodiazepine overdose, we had flumazenil. Can flumazenil antagonize the effect of benzo? Yes. Can flumazenil antagonize the effects of barbiturates? No. Can flumazenil antagonize the effect of alcohol overdose? No. Side effects of barbiturates: CNS depression, respiratory depression, too much barbiturate, coma, and death. And before them you have cardiovascular collapse with vasodilation. Barbiturates are general inducers of the cytochrome P450 enzyme, except secobarbital. Seco is simple. Seco is so nice. Contrast that with benzodiazepines. Benzo metabolized by CYP3A4 and 2C19. There is a drug-drug interaction between benzos and P450 inhibitors. Please do not give them together. There is a drug-drug interaction between benzos and other CNS depressants. So benzo plus barbiturates, that's too much CNS depression. You can kill the patient. Benzos plus alcohol, even worse. Let's talk about the abuse liability for benzos and barbs. Can I get addicted to them? Absolutely. What's the risk? Risk, you can get tolerance. Cross tolerance. This exists between all GABA drugs. So I can get addicted to benzo and barbiturates. Dependence. If I'm not taking the benzo, I'm suffering physical and psychological symptoms. Addiction, coma, and death. Who's at risk? Polydrug users and alcoholics, because alcohol is a CNS depressant. Benzo, CNS depressant. Together, horrible combination. What increases the risk? Combining 2 or more sedatives, such as benzo plus barb plus alcohol. That's a lot. What happens on withdrawal? So these are what? Inhibitory. They inhibit the CNS. When I remove them, I get excitation. I cannot sleep. I'm excited. I have seizure, sometimes life-threatening seizure, especially when I withdraw alcohol and barbiturates. The shorter acting the drug is, the worse the withdrawal symptoms, believe it or not. How can we manage withdrawal? IV diazepam and lorazepam for seizure. Make the patient calm down. How do I prevent the seizure before I withdraw the benzo? Give carbamazepine. The sad story of the death of Marilyn Monroe. No one knows why she died, but it's probably barbiturate overdose. And I can imagine a doofus saying, her face was even more beautiful when she died. Yeah, that's the vasodilation caused by the barbiturates. This is not a sign of beauty. Barbiturates can kill you by circulatory collapse from the vasodilation, hypotension, CNS depression, respiratory depression, coma, and death. And here is a case for you. Please pause. Let's dissect that. You are in the psych ward, female patient, and she's staring into the ceiling, has not moved her neck for 2 freaking hours. And she has manic disorders, so she has mania and other psychiatric disorders. Her vital signs are fine and she's not taking any drug of abuse. What's the most likely diagnosis? The answer here is acute catatonia. Okay, medicosis. What is the difference between catatonia and dystonia? There is a huge difference. Dystonia, defected tone. Here you are having repetitive movements, so you are twitching your arms, grimacing your face, twitching again and again and again. But in acute catatonia, you're not moving. You are paralyzed, stiff, in place, and not moving at all. Yeah, both of them are movement disorders, but they are not the same. Dystonia, I'm twitching, I'm moving, repetitive moving, I cannot stop them. Catatonia, I wish I can move, I'm paralyzed, I'm frozen in place. Why not myotonia? Myotonia is usually a congenital defect due to a genetic problem. I do not see this here. How about neuroleptic malignant syndrome? There is no fever here, so it's not. Serotonin syndrome? No, I don't see it. Malignant hyperthermia? There is no fever. Question: which medication is contraindicated in this case? And the answer here is fluphenazine. Why? It's a typical antipsychotic that can cause dystonia, catatonia, akathisia, tardive dyskinesia, etc. It's horrible. Okay, so do not give fluphenazine to a patient with catatonia, you freaking doofus. What is the gold standard therapy for this patient? Oh, so this patient has catatonia. She's paralyzed in place, cannot move. Oh, she can die. We gotta do something. The gold standard is ECT, electroconvulsive therapy. You shock her. You scheduled her for ECT, and of course there is some protocol and guidelines that you have to follow before you just start it. In the meantime, what medication should you give immediately to treat her acute condition? And the answer is, give a benzodiazepine because it increases the frequency of chloride channel opening. So the open chloride comes in, causing hyperpolarization and inhibition. Therefore, the patient will calm down until you get her to the ECT. Thank you for watching. See you later.